I would like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olevsky, the host for the Vasculitis Foundation's educational webinar series, but I'm also a patient living with MPA vasculitis like all of you. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And now that all the housekeeping is done, I would like to introduce our guest speaker, Dr. Alicia Rodrigue-Pla, MD, PhD, and MBA, is a rheumatologist with a long-standing interest in vasculitis who's in private practice in Fresno, California. She's worked as an assistant professor of medicine at the University of Arizona in Tucson, at the Mayo Clinic in Arizona, and is the former rheumatology division chief at UCSF Fresno. Also, while working on her master's in public health at Johns Hopkins, Dr. Rodrigue-Pla completed a VCRC Vasculitis Foundation Fellowship. So she's the perfect person to talk to us about EGPA today. Welcome, Dr. Rodrigue-Pla.
Hi, thank you very much to the Vasculitis Foundation for organizing this webinar for patients and also for giving me the opportunity of sharing this event with all of you. I would like to start by sharing my slides.
And also, as soon as you do that, if you'll just let us know if you have any disclosures.
Yeah, I do it. Yeah, I'm going back. I have no disclosures. Thank you for the reminder. And so the title, as mentioned, is an overview of EGPA. So I will start by talking about what is EGPA. So it is classified as a rare anti-neutrophil cytoplasmic antibody-associated vasculitis characterized by asthma, eosinophilia, and granulomatous or vasculitic involvement of several organs. And we'll go into more detail about these three aspects during the presentation. According to the Chapel-Hill classification of vasculitis, from 2012, it is classified as one of the ANCA-associated small vessel vasculitis, in addition to microscopic polyangiitis and granulomatosis with polyangiitis. Just by starting by some basic concepts, I would like to remind you what is vasculitis. So vasculitis are heterogeneous diseases that are characterized by the inflammation of the blood vessel. The vessel of the wall of the blood vessel where the blood travels to the organs becomes inflamed for unclear reasons, but it becomes inflamed. So what is initially a normal artery with a normal blood flow, very well organized and directed to the organs, it becomes a little bit erratic with narrowing of the vessel, of the lumen, and the blood has difficulty flowing to the organs, and the organs can become ischemic. That means that they may not get enough blood, and that produces organ damage. In some cases, the inflammation of the artery or of the vessels produces like a dilatation and in the form of a sac that is called aneurysm, and this produces an abnormal blood flow. It doesn't go directly to the organs, but it becomes like a little bit curly in this area. The manifestations of the different types of vasculitis differs depending on the type and the location of the vessels involved. Some of them, they have predisposition for large vessels and they produce one type of symptoms, and some others have, like EGPA, have predisposition for small vessels and produce more symptoms in organs that they have the small vessels, like the kidney, that the glomeruli in the kidney. The nomenclature of the vasculitis has evolved over time with a better understanding of the pathogenesis, and one example is that now we call ANCA vasculitis to those type of vasculitis that they are associated with ANCA, because we know that the ANCA may be important in the pathogenesis of those type of vasculitis, and there are other examples. So regarding the pathogenesis, overall, the pathogenesis of all the vasculitis is similar. We think that there is a stimulus that we call it an antigen, something that triggers an immune response in the vessel. So this stimulus in a host, in a patient with certain risk factors, and we think that several of these risk factors may be genetic, because there is a genetic predisposition to many vasculitis, activate the immune system of that patient, and that immune system activation, for some unclear reason, happens in the vessel wall. And if there is an immune reaction that happens, like a battle between our immune system and some other things that we really don't completely understand. But our immune system is fighting some elements of the vascular wall. So this results in the direct destructive mechanism from the inflammation, and also the wall, the arterial wall, tries to defend itself from the attack, and it like delivers like an arterial response to injury program. It's trying to protect itself. So both of these, the destructive mechanism directly from the inflammation and the inflammatory cells and the response of the artery, result in vascular damage. That is what ends up producing narrowing of the blood flow and ischemic organ, lack of oxygen and lack of blood flow to the organs. At the more granular molecular level, this is more like a specific pathogenesis, a specific mechanism that produces the vascular damage and the organ damage in EGPA. I don't want you to become overwhelmed by all the cytokines themselves included in this slide, but I think it's important to remember from this slide that the IL-5, that is a molecule, like a cytokine, is a molecule produced by inflammatory cells that is very important in the damage that is produced in EGPA. And in this slide, as you can see, it participates at different stages of the EGPA development. So the eosinophil is one of the most important white blood cells involved in EGPA, and the eosinophil needs IL-5 to differentiate from the mother cells, from the progenitor cells in the bone marrow. The eosinophil also needs IL-5 to go from the bone marrow to where normally we find it in the circulation, in the blood flow. And the IL-5 also participates in the migration and differentiation of eosinophils when they go to organs. And in these organs, the eosinophils are known to produce the inflammation that produces organ damage in patients with EGPA. So the IL-5, I just want you to remember from this slide, is a very key cytokine in the process of a patient developing EGPA. And because of that, I will mention later, it has been targeted for many of the newer medications that they are being developed for EGPA. Regarding the epidemiology, the prevalence is approximately between 10.7 to 14 per million adults worldwide. The main age of onset is between 38 and 54, with a median of 40. There is equal predominance of males and females. It is rare in children for some unclear reasons. It's rare in children, but it has been diagnosed in children as well. The rate of positive ANA is approximately 40% of adults with EGPA, and approximately 25% of children have positive ANA. Sorry, positive ANCA, that's it. Mistake there. In patients with childhood EGPA, there is a higher incidence of cardiomyopathy, pneumonic infiltrates, and mononeuritis multiplex, like neurological involvement, happens less frequently in children. I would like to introduce a case of a patient with EGPA. In this case, it's a 47-year-old male patient with a history of asthma that is started in adulthood. He has also had long-standing nasal polyposis with recurrent sinusitis. And then 8 weeks ago, he started with cough, shortness of breath, weight loss, unexplained weight loss, although he said that he lost his appetite, low-grade fevers, and a recent onset of purpuric rash in the legs, and bilateral foot drop. In his lab, his sedimentation rate, one of his inflammatory markers, was elevated. Creatinine was on the upper limit of normality. His eosinophils were elevated in the circulation, they were 40%. Interestingly, he had positive perinuclear ANCA, p-ANCA by immunofluorescence and positive anti-MPO by Alicia. So the symptoms of EGPA can be very, very different, and they can involve many different, because the vasculitis can involve many different organs. So the symptoms depend on what organs and what vessels are involved. If the vessels in the skin are involved, the patients have rash, typically purpuric rash. If they have involvement of the upper respiratory tract, they have nasal and sinus congestion. If they have ear involvement, they may present with hearing loss. When the eye is involved, they may present with pain, redness, and vision loss. They may have heart involvement, and in this case, they have chest pain, shortness of breath. If the lungs are involved, they have cough and shortness of breath. If the GI tract is involved, they present with abdominal pain and diarrhea. When the kidneys are involved, they have blood, and protein in the urine. And when the nerves are involved, they have neuropathy, tingling, numbness, and foot drop. Many of them, they also present with general symptoms such as malaise and low-grade fever. So we recognize that there are three different phases that happens in many patients with EGPA. Some patients are diagnosed at one phase or the other, depending on several factors. Many times depends on the doctors how familiarized with the disease are the doctors that they first encounter. So the first phase that many patients suffer for years is a prodromic or allergic phase that usually lasts several years, and it's characterized by asthma and chronic rhinosinusitis that typically start in adulthood. The second phase is called the eosinophilic phase, and this is characterized by eosinophilia, first in the blood and also in the organs. The eosinophils are increasing in the organs, and we can see that in biopsies. The third phase is the vasculitic phase, and this is characterized by vasculitis, inflammation of the small vessels, and depending on which ones are affected, it can produce mononeuritis multiplex, polyneuropathy, or glomerulonephritis, or skin rashes, purpuric skin rashes. These three phases sometimes overlap, and they tend to happen in most of the patients. Some patients tend to be diagnosed more in the eosinophilic or in the vasculitis phases because the prodromic allergic is quite unspecific, and it takes time to realize that this is part of a more complicated syndrome. There are differences in the clinical presentation between the patients who are positive for ANCA and those that they are negative for ANCA. The ANCA positive patients, both of them have in common this presentation, the eosinophilia, the upper respiratory tract involvement, and the asthma. But the patients with negative ANCA, they tend to have more frequently lung infiltrates, involvement of the heart, and involvement of the GI, of the gastrointestinal tract. Whereas the patients with positive ANCA, they have more frequently involvement of the kidney, peripheral neuropathy, and purpuric rash in the legs. It's unclear why this is different presentation, but this pattern has been repeatedly seen by clinicians and researchers. Regarding the diagnosis, we don't have any specific text. We don't have currently diagnostic criteria. We have classification criteria to distinguish EGPA from other types of vasculitis once you have the diagnosis of vasculitis in that patient, but we don't have any diagnostic criteria. So we go by putting together many of the pieces of the puzzle and trying to make sense of many different symptoms that happen over time. It's very important to get a multidisciplinary or interdisciplinary approach to the management of this vasculitis because it can affect many different organs, and the input from many different specialists is greatly appreciated, and collaboration along the way to treat the patients too. For laboratory testing, we normally check the inflammatory markers. It's very typical that sedimentation rate and C-reactive protein are elevated. We check the renal function and the urine analysis regularly in all the patients, and for the diagnosis too, the urine analysis, if we see blood or protein, it gives us a lot of clues, even when the renal function can be perfectly fine with normal creatinine for a very long time. The ANCA test should be done in every patient that we suspect EGPA. The typical pattern that we see by immunofluorescence is this one here, the perinuclear ANCA pattern, where the staining by immunofluorescence, the uptake is around the nucleus. We check also for hepatitis, tuberculosis, and coccidiomycosis in the area where I am now, California and Arizona, because of the need to many times start immunosuppressant on these patients, and we need to make sure they don't have any latent infection that we need to treat beforehand. We use imaging studies, chest or sinus CAT scan. If they have gastrointestinal involvement, sometimes we have to use abdominal CAT scan, can be helpful, but sometimes we need to do endoscopies. The heart MRI is very, very important for patients in which we suspect cardiac involvement. And also there are other tests as needed. Pulmonary for bronchoscopy, we may need to call our pulmonary friends. Electromyogram and neurology consultation can be very important for patients with neurological symptoms. Biopsies are highly desirable, especially on these rare diseases, because they can help a lot to confirm the diagnosis. Anything that we can biopsy, skin, lung, kidney, sinuses, we like to biopsy the one that is less traumatic for the patient, the one that is less aggressive. If we can get a skin biopsy and it gives us the diagnosis, many times we can avoid other internal biopsies of other organs. ENT evaluation for patients with upper respiratory symptoms is very helpful too for us. So I just wanted to talk a little bit about the differential diagnosis. It needs to be differentiated from many other diseases like hypereosinophilic syndromes, allergic reactions. But one of the main differential diagnoses is between the three different types of small vessel ANCA-associated vasculitis. It's important to differentiate it from GPA and from MPA. These are the different characteristics. The ANCA pattern in EGPA is the only one that in which it predominates the cytoplasmic ANCA pattern with positive PR3, and in MPA and EGPA is more the perinuclear ANCA by immunofluorescence that becomes anti-MPO in a specific ELISA testing. The granulomas are seen in EGPA and GPA as their name suggests, but not in MPA. Eosinophilia is characteristic only of EGPA. Pulmonary involvement and kidney involvement can happen in all the three types. The diffuse alveolar hemorrhage is rare in EGPA. It's more frequent, up to 25% of the cases in GPA and MPA. The sinus and nasal symptoms are typical of EGPA, or EGPA and GPA, but not MPA. This is the differential characteristic between GPA and MPA, the upper respiratory involvement. And the subtle nose deformity characteristically only happens in GPA. We don't see it in EGPA, even when there is sinus nasal involvement. The tracheobronchial involvement doesn't happen in EGPA, but it can happen in the other two types. Now I want to change gears to the treatment. In general, there are guiding principles. We have to take into account that the damage occurs quickly and is often irreversible. Both inflammatory and secondary ischemic components contribute to the damage, and inflammation and asthma may require control over months, years of lifetime. So we try to treat patients for a short time, as I will mention in the next slide, but sometimes some of the symptoms, they don't really get very well controlled, and we need longer treatment that we would like to. For medication, we use glucocorticoids for rapid inflammation control, and this usually followed with immunosuppressive medication, several types of immunosuppressive medication that in the long run, we consider that they have less potential side effects than glucocorticoids. So there's a treatment timeline. We try to divide the treatment in two main phases. The first one is the first 3 to 6 months, and we call it the induction or remission phase. That phase, and during that phase, our goal is to reduce the inflammation and prevent organ damage. The following approximately 18 months are called maintenance of remission phase, in which we just focus on relapse prevention. For the first phase, we use different agents, mostly corticosteroids, high doses of either oral or intravenous ones. We can also use cyclophosphamide, Rituximab, azathioprine, mycophenolate, Mepolizumab. For the maintenance phase, we basically can use almost the same agents. We try not to use prednisone. We try to stop prednisone or taper it down slowly. And cyclophosphamide is not used for this phase due to the toxicity that has in the long run. And we want to use it for only the shortest possible period of time. So in cases of refractory disease, we have other things that we can use. We can use plasma exchange, we can use IVIG, we can use interferon alpha, TNF inhibitors. We don't have a lot of data about these treatments. We don't have many clinical trials, but we use them in cases where we don't have anything else that we can use. The ACR, American College of Rheumatology, and the Vasculitis Foundation, they issued some guidelines for treatment of EGPA in 2021. And what they recommend is in cases with active severe EGPA, we use induction of remission using pulses of IV glucocorticosteroids or high doses of oral glucocorticosteroids in combination with cyclophosphamide or Rituximab. This is in cases of life-threatening disease. If the patient go in remission on cyclophosphamide, we switch to another less toxic medication in the long run, like methotrexate, azathioprine, or mycophenolate. In cases of severe disease relapse after remission with cyclophosphamide or Rituximab, we treat with high doses of glucocorticoids and with Rituximab. And we try to avoid repetition of cyclophosphamide. In cases where the EGPA is not severe, is not life-threatening, the option that they recommend as the first option is glucocorticoids plus Mepolizumab. I will talk about Mepolizumab later. And in the second case, we can combine, if that doesn't work or is not an option for the patient, we can use glucocorticoids with other immunosuppressants like methotrexate, azathioprine, or mycophenolate, or even with Rituximab. But in these cases, we want to avoid cyclophosphamide because of the high level of toxicity, and probably it's a very too much medication with many potential side effects for patients that they don't have severe disease. If they fail, if they have relapse, then we add glucocorticoids and Mepolizumab if they have been treated with the other agents, or we add other agents if they have been treated with Mepolizumab or Rituximab. We just try other combinations. The EULAR also issued some guidelines in 2022, quite similar to the previous one. The main concept, I think, is that they also agree that in patients with life-threatening disease, they recommend to start with cyclophosphamide or Rituximab, and if no life-organ disease, they recommend to start with only prednisone, only glucocorticoids, or Mepolizumab. So I would like to focus a little bit on anti-IL-5 biological therapies because they are the newer medications that they are being developed for EGPA as well as for many other vasculitis. So as I mentioned before, the eosinophil is one of the main cells that participates in the damage in patients with EGPA. So, and it's only related to IL-5. IL-5, it has a receptor on the surface, in the eosinophil, it has receptors in the surfaces of IL-5, and IL-5 helps with the differentiation and the migration and the maturation of eosinophils. So IL-5 is a cytokine that is involved. Cytokine means that it's a molecule that is produced by cells, by inflammatory cells during the inflammation, during the battle that happens where it's an inflammation in one of our organs. So IL-5 is a cytokine involved in the induction, maintenance, and amplification of airway eosinophilia in asthma. So because IL-5 is so important in EGPA, as I mentioned in one of my first slides, they have been developing antibodies against IL-5 to try to block it at different levels. So Mepolizumab is one of the antibodies that was initially approved for asthma and is not currently approved for EGPA too by the FDA. So Mepolizumab is an anti-IL-5 monoclonal antibody and the only approved drug for EGPA until the moment. Benralizumab It's also another monoclonal antibody, but in this case, it binds to the IL-5 receptor, alpha subunit, and leads to rapid eosinophil depletion via antibody-dependent cellular toxicity. There is another anti-IL-5 medication that is has been developed. It's called reslizumab, and it's an antagonist monoclonal antibody, and it's indicated for adult maintenance treatment of patients with severe asthma who are 18 or older and with eosinophilic phenotype. It has not been approved. None of these two, Benralizumab or reslizumab, have been approved for EGPA so far, but they have been approved for asthma. So these are the three anti-IL-5 therapies that they are currently being studied in EGPA or being approved. Mepolizumab is already approved, and it was approved in the MIRA study. Reslizumab there is data in the NIH clinical trial website telling that they say phase 2 clinical trial, but they don't have any update information, and they only have one site in Colorado, and the last information I found is from 2017, and I haven't been able to find more information. So I'm guessing that this study is now on hold, and it's called the RIGHT trial. Benralizumab has had a recently published phase 3 clinical trial in EGPA. It's called the Mandara, and it has very promising results for treatment of patients with EGPA, as I will mention in the next few slides. Regarding Mepolizumab, I just wanted to mention something about the clinical trial that it was published in New England. Mepolizumab is a humanized, as I mentioned, IL-5 antagonist monoclonal antibody. In the MIRA study, they include patients with adult patients with relapsing refractory EGPA and 4 or more weeks who were on 4 or more weeks of oral glucocorticoids. The patients received Mepolizumab 300 milligrams subcutaneously every 4 weeks, or placebo plus standard of care for 52 weeks. So it went for 1 year. 135 participants were randomized, half to placebo, half to Mepolizumab. So, the Mepolizumab resulted in significant more weeks in remission and a higher proportion of patients in remission in EGPA than in placebo. And Mepolizumab allow for reduced glucocorticoid use. So also, like as you see here, the participants have less relapses with Mepolizumab than with placebo. So that made the FDA approve that medication for treatment of patients with EGPA. Then regarding the Benralizumab, there has been a phase 3 clinical trial recently published too. And in this case, they compared Mepolizumab with Benralizumab, not with placebo. And they found that in the primary endpoint at week 36-38, Benralizumab demonstrated non-inferiority compared to Mepolizumab for the primary endpoint, that it was achieving remission at weeks 36-48. Both of them, they produced a decrease in the daily average dose of glucocorticoids, so they have a very good profile for steroid-sparing agents. And Benralizumab and not Mepolizumab got a 100% reduction of glucocorticoids, that it was significantly, statistically significant when compared to Mepolizumab. Regarding the blood eosinophil count, both of them decreased it, but in this study, Benralizumab got it at a lower level than Mepolizumab. So the Mandara study demonstrated non-inferiority of Benralizumab versus Mepolizumab over 52 weeks in patients with relapsing refractory EGPA receiving a standard of care therapy. More Benralizumab recipients achieving 100% reduction of oral glucocorticoids. Benralizumab was well tolerated. There were no safety concerns within any of the two medications. And the authors concluded that Benralizumab provides clinically meaningful benefit in EGPA, and I think that they are probably now in the process of getting it approved for the FDA based on the results of this study that it was just recently published. That was February of this year, 2024. So there is another IL-5 antagonist, the reslizumab. As I mentioned, there is only one site listed in the NIH clinical trial website, and the current status is unknown. I couldn't find more information. I think probably they are holding the recruitment for some reason. I just want to finalize telling that there is some few take-home messages I would like you to remember. EGPA is progressive multi-organ immune system disease that should be suspected in patients who present with unexplained systemic inflammation and damage of multiple vascular distributions. It often requires a multi-specialty evaluation because of the different organs that it may affect. And the prompt diagnosis is essential, it's very important to prevent ischemic organ damage. The treatment with glucocorticoids and immunosuppressants is recommended in almost every patient with EGPA, especially they don't respond 100% to glucocorticosteroids. And I think the IL-5 inhibitors are promising as new therapeutic targets. I wanted to thank again to the Vasculitis Foundation for the opportunity of being with you all here today, and I'm open to any questions that you may have.
Okay, thank you so much, Dr. Rodrigue-Pla. If you could stop sharing your screen now, we could just see our faces and we could get to the questions. Thank you so much. I learned so much just from that presentation, and especially how difficult it is to diagnose EGPA. There seem to be so many things to decide between GPA, MPA, and EGPA. I did want to ask the patients that are watching today to please make your questions as specific as you can. And as a reminder, we can't ask Dr. Rodrigue-Pla to comment on any personal medical questions because she is not your doctor. But she will answer general questions. We've gotten a few, so I will start with the ones that we've gotten. Let's see. I liked this one. I think you said to ask here, many of us have no eosinophils because of prednisone, Nucala, et cetera, but still have flares or need additional meds to manage the EGPA. What can cause flares in EGPA when the eosinophils are zero?
One thing would be what kind of flares? It means like asthma with zero eosinophils, or, many things can produce flares in these diseases. I think probably many allergens. I wonder infections. Infections can produce flares too. I don't think the eosinophils are the only molecule or the only cell that is involved in this vasculitis. I think it's one that has caught our attention more than others because it differentiates this vasculitis from other ones. But I'm sure there are many more cells that they participate. I will be very surprised if the T cells are not involved or other cells. Probably eosinophils will be more related to the asthma-related symptoms or even the skin symptoms, because many of them, they are mediated by allergic reactions. But I'm sure that vasculitis symptoms, other cells are there, and they also produce the inflammation in the organ and the damage.
Right.
And stress can produce many of these flares too in many autoimmune diseases, not only in GPA, but we see stress. And I always wonder if it's mediated by the steroids, because we produce stress. It's like steroids is one of the hormones that we produce in our body physiologically when we have stress. But patients with vasculitis or with autoimmune disease, they probably have been on prednisone for a long time, and they may have not the same response, but they may not be able to respond in the same way to this stress, or they may have even some kind of alteration of the adrenal hypothalamus axis to start with, and they don't react to stress in the same way that it's someone that has autoimmunity. And that can be part. Maybe they don't have the same reserve of endogenous steroids to respond to stress, and then they have inflammation in organs. I'm sure the eosinophil is not the only cell involved.
Right. And so many doctors have told us that it is not just about what is seen in the labs. There's so many other factors to take into account with this. So we appreciate you reiterating that. I did hear you say this, but it was a little bit quick. And one of our patients wants to know what DAH means. You said it was in the comparative slide.
Diffuse alveolar hemorrhage. Sorry about that.
Diffuse alveolar hemorrhage. I heard you, but I wasn't sure I could repeat it.
Yeah. So it means that the patient bleeds in the lungs. So these are patients that they present with cough, with a lot of blood in the cough, not just a few streaks. like they present with blood. And then when we do an endoscopy, typically we see that we get several tubes of blood, and when it's some kind of damage, because people have been coughing a lot and they have like damage in the upper respiratory tract, the blood decreases. But when it's diffuse alveolar hemorrhage, it means like there's a lot of blood in the lungs. The blood doesn't decrease as we get more and more tubes. It continues being very, very red and very, so it's.
Thank you for that clarification. And some of our viewers today are asking about your slide presentation. I just want to assure them that this is recorded and it will be on the Vasculitis Foundation's YouTube channel shortly. But also, is it okay with you if we share your slide presentation with patients if they ask for it, Dr.?
Yeah, it would be okay. I will just like to change the typo that they saw, the ANCA for the ANA instead of ANCA. So yeah, but it will be okay to share them.
Okay, great. One of the other questions that came in is, how often do you see elderly patients diagnosed for the first time? My father was diagnosed 14 months ago at age 83.
It's not very frequent, but we see them. I see them, yeah. It's more frequent 50s, 60s, like what it has been described, but I think now that people are living longer, we see more and more autoimmune diseases in all elderly people than before. We were not even thinking of that.
You know, similarly, I know your presentation even said that it's kind of rare to see EGPA in children, but you have had children diagnosed with EGPA. One of the questions is, could you tell us what your youngest patient is that you've treated with EGPA?
Actually, because I'm not a pediatrician, like I'm not a rheumatologist, pediatric rheumatologist, the youngest one I have seen is a patient that transitioned from pediatric care to adult care. So she was 18 when I started seeing her. She had been diagnosed when she was 14. So by the time I saw her, she was doing quite well. No cardiac involvement, fortunately. That it was my main concern always with pediatric patients. By the time I saw her 4 years later, she was doing quite well, quite stable.
Okay, that's good to know. And I know you covered this in your presentation, but several people are asking about it, so maybe just we can reiterate. Can you explain how the drug Mepolizumab could help patients? Is it actually reducing taking steroids or glucocorticoids, or is it?
It's basically that's what we call like decreasing the dose of steroids. Like I think we have been for years trying to find something to avoid using steroids, because steroids are wonderful in the short time. I always think, they're having questions about if they save lives or not. In my experience, I would say they probably save lives on the short term. Many patients with diffuse alveolar hemorrhage, they come to the hospital bleeding. We put them on high doses of steroids, and it's the thing that is more rapid, like it's the quicker medication that we have to save the patient's life. I think it's saved by that, but then in the long term, they have many, many potential side effects. So we are always looking for steroid-sparing agents. But all the other medications, even cyclophosphamide, it takes several days to several weeks to have any effect. So the premise on the steroid is the one that is very quick to act. In the long run, it has problems. So we haven't been able to find a substitute. We haven't been able to find something that makes us not to use steroids anymore. But we are trying to find something to decrease the dose of steroids, because the steroids in the long run have many potential side effects. High blood pressure, high cholesterol, diabetes, cataracts, fractures, osteoporosis. So Mepolizumab, in the clinical trial, it was added to the standard of care with glucocorticoids and some patients with the other immunosuppression agents. And what they found is like we could decrease the steroids faster, and we use less total dose of steroids in patients that have been on Mepolizumab compared to the ones that have been on no Mepolizumab. So that's how we use it.
Okay, thank you for the clarification. Just so many people were asking about it. Also, here's another really great question. Have you any experience with EGPA patients successfully maintaining remission off all treatment?
Um, a few, a few to be honest, but not too many. The main issue I have had in the long run, it has been the asthma, probably the asthma symptom. Many times it's not constant. They have a more normal life than at the beginning, but the asthma from time to time comes back. Yeah, I think I probably have only 2 patients that I have followed for years. Maybe also because I have moved from one institution to the other. I would wonder if I would have stayed, if I would have more. But patients that I have, like for example, this pediatric patient was very stable by the time I got her and she was 18. She was coming to see me and she was off medication, but for some medication for asthma. She didn't have many asthma attacks, but from time to time she presented saying, I know my asthma is trialing. But she didn't have any other symptoms. She didn't have any other skin rashes that she had at the beginning. She didn't have any of the skin rash in the legs that had at the beginning, the vasculitic one. So I thought she was doing pretty well. But the asthma is the part that even these patients that were stable of medication, I always follow them because they may have some asthma symptoms from time to time.
Right. Well, that makes sense. The next question is, are vaccines such as flu, COVID, and shingles recommended for someone in treatment for EGPA?
We recommend those vaccines, for patients with EGPA. I know there have been a lot of controversy about, especially the COVID vaccine, producing vasculitis or cardiac problems. But with the data that we have, having COVID also gives a lot of problems, especially in patients with EGPA, with respiratory problems. So we recommend the vaccines.
Okay. And I think that's been said a lot, but we appreciate you saying it again. Do you know the timeline of approval for the use of Benralizumab to treat EGPA? What was the dosing frequency in the study? Was it 30 milligrams every 4 weeks? This is the question.
I will have to check on that, but I think it was the dose. I think it was 30 milligrams. I think so. I will have to check on that. But the timeline, I'm pretty sure that the company is really fighting to get it approved as soon as possible.
Yeah.
And with the results of the trial, I think especially the significant difference with Mepolizumab in decreasing the glucocorticoid, in 100% glucocorticoid reduction, I think that can make the FDA quite excited about approving it soon. But I cannot say because I know this has a lot of regulations, and I would say I would hope it's approved by the end of the year, but I know it may take longer.
Well, as with everything else that's important to us, we have to wait and see, but it will happen at some point. Here's a good question. Is it normal to have a lot of surgeries in the sinuses, like every year, and inflammation in other organs?
Many surgeries. Well, every year, I'm not sure. I have seen patients having recurrent surgeries, but many times at one point they stop. Most of the patients I have seen at one point they stop having surgeries, especially, or at least it can be more time in between surgeries. Every year, I will see if they can optimize the treatment. I mean, even the local treatment a little bit better to put some more time in between surgeries because it can produce a lot of damage too when they do surgery. But it will depend on the particular case. If that what the otorhinolaryngologists recommend, I will go with their recommendations. But it's a little bit. I haven't seen them so often in most of my patients. No.
Okay, and back to the Benralizumab. What percentage of patients develop antibodies to Benralizumab over time? Do you know that, or is that still being studied?
I don't think for Benralizumab. I mean, the clinical trial was only 1 year, and it was published in February. So I don't think they have data. I didn't mention anything about that in the paper as soon as I read it, and I don't remember anything about that. We probably did the medication, either another clinical trial to follow up for 1 additional year or data when it comes to the market to know more about that, as it has been happening with other biologic medication.
Okay. This is interesting. Rituximab was not listed on the IL-5 inhibitor slides. In addition to B-cell interaction, does Rituximab also inhibit IL-5?
As one of the, I'm not sure about that question. I know Rituximab as the CD20, CD19 inhibitor of the B cell, but I haven't. We typically don't know Rituximab as one of the IL-5 inhibitors. I don't think it's one of the main mechanisms of action. It could be because many of these molecules they interact with one or more receptors, but it's not something I'm aware of.
Okay. Well, you can only tell us what you know, so we appreciate that. How common is neuropathy? Also, what do you recommend as a course of treatment for it if they have it?
For neuropathy, for neurological involvement, neurological involvement is considered to be one of the severe manifestations of EGPA, especially because it can produce foot drop or hand drop too. And how often it is not, unfortunately, it's not very frequent, but I will say probably 20-30% of the patients with EGPA can present with neurological involvement. And the treatment, probably the recommended treatment, the one that we have stronger evidence is still high doses glucocorticoids and cyclophosphamide. In some cases, especially if the patient is young, we are very concerned about long-term consequences on fertility of cyclophosphamide and even cancer. We may use Rituximab, but there is probably more evidence with cyclophosphamide, and it's difficult to treat. If we don't treat it very early, it's very difficult that it will respond to any kind of therapy. As in other vasculitis, it happened with GPA too. Like many times we try the medication, but if it's not treated in the first stages, the organ has been already established and there's not a lot of inflammation ongoing, it's difficult that they respond even to cyclophosphamide or Rituximab with high doses of steroids.
Okay, thank you for that. And again, back to asthma, we keep getting a lot of questions about this actually. How is asthma actually treated when someone has EGPA? Is it just the medication they're receiving for the EGPA, or is something additionally done for? I know that's such a big question.
Yeah, I typically like to treat the asthma in collaboration with the allergologist. That is normally the person that treats asthma. I use the medication for EGPA. I use the Mepolizumab, but I always like to send them to the asthma doctors, and many of these patients, they use inhalers and they use the medication that they add for asthma.
Okay. And a few people asked this question, and before you answer this question, I just want to tell everybody the Vasculitis Foundation has some videos specifically related to this, but they want to know your thoughts on diet and anti-inflammatory diets and how does that help EGPA?
In general, in all the autoimmune diseases, maybe in others too, but I'm more aware of autoimmune diseases. I think the diet is very important. I see that in many of my patients, they talk about the anti-inflammatory diet. I feel it even on myself when have vasculitis, but when depending on what I eat, I can feel better or worse for sure, like either upset stomach or bloating. So my patients, almost all of them, and I'm convinced, like the anti-inflammatory diet, like avoid processed food, carbohydrates, high number of sweets. It really helps. Like increase the number of veggies, the proportion of veggies, the fruits, and just remove sugar. Like if you like sugar, try to use the natural one in fruits, but try to avoid anything that is processed food, any bakery, sweets. Limit the bread, and I would say almost, I have many patients tell every kind of bread, not even the brown. I like any kind of bread. It makes gluten. It makes me feel not good. So I think that's very important. That's very important. Like healthy lifestyle is very important. As I mentioned, I think there is something related to stress and the production of our own steroid steroid doses, and we should try to avoid stress, have a healthy lifestyle, diet, avoid sugar, avoid the sodas that they have a lot of sugar and empty calories. All of that, I'm convinced it helps.
Well, you're reiterating what every doctor has said in every Vasculitis Foundation webinar about doing the right thing with your diet is helpful. So we appreciate that. There's a couple of questions about tavneos and EGPA. It says, why is tavneos only for ANCA positive? We can't use it, right? And then somebody else was mentioning that they were getting turned down by insurance, and maybe that's the reason. But is there some information about tavneos and EGPA?
I mean, the only information is like it doesn't seem to work in EGPA, so I never tried to use it in EGPA. I mean, it was, I think it's developed by the mechanism of action for like GPA and MPA, and EGPA is different. Like in many of the guidelines, they when they talk about ANCA vasculitis and when they do many of the studies, like GPA and MPA have a similar pathogenic mechanism, but EGPA is quite different. So they probably need different treatments. And tavneos never crossed my mind to use it for EGPA.
Okay. And here's another lab question. Is extremely high IgE greater than 5,000 a common condition with EGPA? And I don't even know what IgE is.
So IgE is, it's typically elevated in patients with EGPA, but because it's part of the allergy reaction too. But when it's very high, we are more concerned about hypereosinophilic syndrome. That is, it can be difficult to differentiate from EGPA. That's one of the most common consultation that we get in the hospital with patients that they are admitted with elevated eosinophils and many different organs involvement too. It's like, is this EGPA or is hypereosinophilic syndrome? So it could be EGPA, but I think it would be important to rule out hypereosinophilic syndrome first.
Okay.
So
well,
consultation with hematology, that they are the best ones to differentiate that. It will be very helpful.
Well, thank you for that. I'm going to do one final question because I'm sorry to everybody who we didn't get them answered. We will do our best in the future, but we have got one final question because we're running out of time. Who should be on my team besides a rheumatologist? Should I have a pulmonologist on my medical care team, or who else?
I mean, it will depend on the organs that you have involved, but I will say in most of the patients, the pulmonologist or the allergy doctor, if they have asthma, in most of the places, asthma is treated by allergy, not by pulmonary. But if they have like infiltration in the lungs or possibility of diffuse alveolar hemorrhage, pulmonary can be very important too. And the allergy doctor for the asthma, if they have any purpuric rash, the skin doctor may need to do a biopsy. Sometimes they may need to repeat biopsies. Not all their rash is vasculitis. So sometimes patients have other rashes in the future and they may need a biopsy to know what is that. And of course, the kidney doctor, the nephrologist, very important. Many of these patients, they have glomerulonephritis. If they have neurological involvement, neurology, and if they have cardiac involvement, they will need a cardiologist. Gastroenterologist if they have any GI symptoms. So the rheumatologist is like the PCP of EGPA, but we normally, and ENT, of course, otorhinolaryngologist, I need many of them to do sometimes like cleaning, recurrent cleaning, sometimes surgery, but many of them, they do like periodic cleaning to try to avoid surgeries too, like formal surgeries. So all of these specialists, ophthalmologists, if they have eye involvement too.
So that is a great way to look at it, that the rheumatologist is like the PCP for EGPA patients. So that's your primary person, and that person will guide you to other specialists that you need, depending on what symptoms you have, what's going on with your EGPA. So thank you for clarifying that. That was enlightening. And I just want to say thank you so much for spending your time with us today, Dr. Rodrigue-Pla. As a reminder to everybody, today's webinar will be published on the Vasculitis Foundation's YouTube channel soon. So you will see the presentation and all the questions that we answered. And each person that registered for the webinar today will also receive a follow-up email with a link to where it is on the YouTube channel. And also, I did want to share one more thing with you all today. Let's see if I can share my screen. Yes, there it is. And thank you so much to all of you. But also, I wanted to say, just take a minute before we finish up and ask my fellow patients, did you ever wonder how you could have an impact on important vasculitis research? The answer is that you should join the Vasculitis Patient-Powered Network, which is the VPPRN. I'm a patient champion for the VPPRN because I'm also a patient living with vasculitis. And I encourage other patients to join the VPPRN and to complete their biannual forms. Actually, it's very simple. It takes maybe 10 minutes twice a year, and it's all online. And I can't tell you everything you need to know about the VPPRN, so I would encourage you to learn more by visiting their website, which is, as you see in the slide, www.vpprn.org. And what I can tell you is it's a global patient registry. Patient data, that means your data, drives research in vasculitis, and providing researchers with information about you and your experience is key for advancing our knowledge of vasculitis. And having said that, we would like to thank the Vasculitis Foundation for hosting these webinars and our sponsors, Amgen, AstraZeneca, and Novartis, and of course, Dr. Alicia Rodrigue-Pla for spending her time with us today. We know how important your time is to your patients, but we appreciate you educating us today. So thank you so much.
Thank you.